7:30, so we'll go ahead and get started. Thanks to everyone for joining us on this early morning. A few announcements before we get to today's presentation. Our next Grand Rounds will be February 3rd, and our speaker is going to be Dr. Sunny Lineber, and she's going to be talking to us about medication management and deprescribing in older adults. Our next journal club will be February 10th, and our presenters for that will be Drs. Susie Kim and Sarah Beck. Other announcements, after today's Grand Rounds, you will receive an email with a link to today's recording and a copy of the PowerPoint presentation. There will also be a link to an online evaluation, so if you could please take a moment to fill that out and send it back, we'd really appreciate it. Please feel free to submit questions in the chat or Q&A boxes during the presentation, and hopefully we'll have time to get to those at the end. So I'm really thrilled to introduce our speaker today, Dr. Cecilia Low Wang. Dr. Low Wang is an endocrinologist and professor of medicine here. She's also a clinician scientist at the CPC Clinical Research and a fellow of the American College of Physicians. She earned her medical degree at the University of Rochester and did her residency and chief residency in internal medicine at the University of Utah. She then came to Colorado for her fellowship in endocrinology and joined the CU faculty. She was initially at the VA, where she did research on cellular mechanisms of atherosclerosis, and then came to the university in 2012. Dr. Low Wang currently chairs the FDA Endocrinology and Metabolic Drugs Advisory Committee and helps design and run clinical trials for drugs, devices, and biologics. She oversees medical safety for various clinical trials and adjudicates major adverse cardiovascular and limb events, as well as bleeding endpoints for international multi-center trials through the CPC. She's on numerous committees for the Endocrine Society, chairs the American Association of Clinical Endocrinology Disease State Network and Diabetes, and is a member of the Academy of Medical Educators, as well as the program director for Primary Care Diabetes Fellowship at CU. She directs the glucose management team at the University of Colorado Hospital. So we're just thrilled to have someone who has so much experience and wears so many hats and is going to be talking to us today about hypoglycemia in older adults. So thank you so much for joining us, Dr. Low Wang.
Dr. Hildreth, thank you so much for inviting me. It's a pleasure and a huge honor for me to be here with you this morning. So let me go ahead and share my screen. And I learned how to do this morning. So not the sharing screen part, but the sharing a portion of the screen part. Okay, can everyone see this okay?
Yes, looks good.
Okay, wonderful. Thank you. So let me get started. This morning, I'd like to talk about hypoglycemia in older adults. And this title, What Should We Target for Glucose Control, is a little bit, there are many different layers to this. So the first is, what numbers should we target? That's one question. The second is it really A1C that we should be targeting? And the third is it enough to only target an A1C? So I'll talk about those different aspects in the next 50 minutes or so. So here are my disclosures. I have a couple of inpatient continuous glucose monitoring trials that will be starting in the next probably month or two. And then I'm also PI or co-PI on a couple of different trials, and I work at CPC Clinical Research for part of my FTE. So my objectives this morning are to define hypoglycemia according to international standards, and I'll give a bit of background on that. Recognize risk factors and clinical clues for undetected hypoglycemia and hypoglycemia unawareness. And then lastly, to tailor diabetes treatment regimens for older adults with diabetes, including appropriate referral for use of diabetes technology. So just a little bit of background. I think you've probably seen these data in many different ways, but the current National Diabetes Statistics Report from 2020 estimates there are about 8.4% of US adults have diagnosed diabetes. So that's at the tip of the iceberg or the tip of the triangle. All diabetes, undiagnosed and diabetes, makes up an extra 2% or so. And then of course, prediabetes affects more than 1 in 3 US adults. So the other aspect of this is, what about the prevalence of diabetes in US adults age 65 or older? So the incidence of diabetes increases up to about the age of 65, then it levels off. And of US adults age 65 and older, more than a quarter have diabetes. and almost half have prediabetes. So it's really a huge number of people who are affected. And of this, of course, the vast majority have type 2 diabetes, 5 to 10% have type 1 diabetes, and then there are many people who have other forms of diabetes, including pancreatic diabetes, steroid-induced diabetes, etc. So what is diabetes in adults, older adults, like compared with other age groups? So of course, there's a lot of heterogeneity, and one of those aspects of heterogeneity is diabetes duration. So there are actually a fair number of people who are age 65 or older who are diagnosed with diabetes at that point. And so they might have very recent onset or new onset diabetes at this older age, which is, of course, very difficult to deal with, this new diagnosis of a chronic condition at that age or any age. And then also there are older adults who have longstanding diabetes, so onset in middle age or earlier. And that subset of people are more likely to have a history of retinopathy. Diabetes in older adults is associated with the highest rates of major lower extremity limb amputation, myocardial infarction, visual impairment, and end-stage renal disease. And there's a cutoff kind of at the age of 75 for complication rates, which are much greater in adults age 75 or older compared with the slightly younger age group. The last thing is that it used to be that we had a lot of emergency room visits and hospitalizations for hyperglycemia in adults, but now actually we've seen a much higher rate of hypoglycemia ER visits in adults, especially age 75 or older, compared with the general population with diabetes. So why do we care about hypoglycemia? Of course, there are many different reasons, but we know that hypoglycemia, even when you don't lose consciousness, so slightly milder hypoglycemia, significantly impacts morbidity and mortality in individuals with diabetes. So about a fifth of non-severe hypoglycemia happens when you're sleeping. And so it can cause sleep disruption and a lot of anxiety in both the patient and the family. And then there's also a linear relationship between the severity of hypoglycemia and decrements in quality of life among subjects with type 2. And after an episode of hypoglycemia, subjects usually report poorer adherence because of fear of hypoglycemia. There's more resource utilization and diminished treatment satisfaction. So lots and lots of quality of life issues with having episodes of hypoglycemia. And of course, this fear of hypoglycemia impacts both patient behaviors as well as healthcare provider behaviors. So what do we mean when we talk about hypoglycemia? So the International Hypoglycemia Study Group came out with definitions of hypoglycemia a few years ago. And this was really just to try to standardize the definition as well as to add on a definition of this level 2 hypoglycemia. So of course, in individuals without diabetes, we think of a normal glucose as being 60 or higher. In diabetes, we set a higher target for various reasons, but a lot of the time it's because glucometers aren't as accurate at lower levels, and so there's a greater degree of inaccuracy. That's one. And the second is that oftentimes in people with diabetes, we're doing something to lower the glucose, so we need to have a little bit more latitude for not causing hypoglycemia. So that's why in patients with diabetes, we set this level of 70 or less. So that's considered level 1, so glucose alert value of 70 or less. And the thought for this study group definition was for clinical trials so that we could compare apples to apples for hypoglycemia. And so their comment is that, in a lot of clinical studies, this may or may not be required to be reported routinely, depending on what the study is related to. Level 2 glycemia was really the important thing that came out of this study group definition, which was a level 2 glucose was important to report in clinical trials, and it's a glucose of less than 54. So this is sufficiently low to indicate serious, clinically important hypoglycemia. So that was kind of a big thing that came out of this, because in the past, people had been using less than 54, less than 50, less than 40, and we couldn't compare between trials. And then level 3 was kept the same. And so this is defined by the American Diabetes Association as severe hypoglycemia. So it's any severe cognitive impairment due to hypoglycemia that requires assistance of another person for recovery. So of course, I've touched on this before, and as you know, adults who are age 65 and older with diabetes aren't all the same. There are some older adults with diabetes that might have very little comorbidity and are active. There are some that have other underlying chronic conditions. They might have substantial comorbidities. They might have limited cognitive or physical functioning or frailty outright. And of course, individuals have different preferences for how intensive they'd like their glucose control to be, how they want to get there. And then also there are differences in diabetes treatment and self-management knowledge, health literacy, and of course, numeracy. And so there's a lot of ongoing research to try to classify older adults with diabetes based on comorbid illnesses. So this is kind of what's been falling out of a lot of the research is these three categories. So older adults who are healthy, those are on the far left, a geriatric population with associated obesity, hypertension, arthritis, and often incontinence. And then there's a cardiovascular subgroup, people who are disproportionately affected by coronary artery disease, heart failure, stroke. And this group has a higher level of frailty and mortality. So when we try to individualize glycemic goals in older adults, there are a lot of things that can affect function, quality of life, the ability to care for diabetes, and then also increasing the risk of hypoglycemia. And all of these overlap. And so having moderate or severe comorbidities, especially lower extremity or foot complications, neuropathy affecting dexterity and balance, having had a stroke with residual functional limitations, and then periodontal disease affecting food intake. There are also the different geriatric syndromes that should inform individualization of glycemic goals in older adults, including cognitive dysfunction, functional impairment, risk for falls and fractures, polypharmacy, always a huge issue, depression, vision and hearing impairment, chronic pain due to diabetic neuropathy or other causes, and urinary incontinence. And of course, this last is a big factor just because hyperglycemia, of course, can worsen that. So of course, it's a balance. I'm trying to individualize these glycemic goals. So there are the different comorbidities, geriatric syndromes, many of which increase the risk of hypoglycemia or difficulty managing a regimen. But on the other hand, we're also trying to avoid uncontrolled hyperglycemia. And the reason for that is that when glucoses are consistently above the renal threshold for glycosuria, which is about 180 to 200, but can vary, there are increased associated risks for dehydration, volume loss, electrolyte abnormalities, urinary incontinence, dizziness, falls, poor wound healing, and of course, hyperglycemic hyperosmolar syndrome. And so the ADA statement is, and this has kind of been repeated for over a decade, even though it's appropriate to relax the glycemic targets for older patients with a history of hypoglycemia, a high burden of comorbidities, and limited life expectancy, goals that minimize severe hyperglycemia are also indicated for almost all patients, except at the end of life. And so I wanted to step back a little bit and just remind you a little bit about some of the background here. And this was written by Ralph DeFranzo, who had gotten a Banting medal, Banting award by the ADA. And he calls this the ominous octet of hyperglycemia in type 2 diabetes. And so our understanding of type 2 diabetes has really progressed over the past few decades. And besides the pancreas, and besides just the beta cell, we know that alpha cells or overproduction of glucagon is important in causing hyperglycemia in type 2 diabetes. We know that there's liver insulin resistance with increased hepatic glucose production. We know that there's decreased glucose uptake in peripheral tissues, especially skeletal muscle. But then we've also learned a lot of other things. So we know that there are problems in fat metabolism. There's decreased effects of incretins, GLP-1 and GIP. We know that there's insulin resistance at the vascular level as well. So probably problems with microvascular recruitment, and then inflammation. And lastly, problems with glucose reabsorption. So increased glucose reabsorption. And then lastly, I actually don't see the gut here, but I would probably add the gut here, which besides the incretin effect, there's also rapid gastric emptying. So with diabetes, we worry about complications, we worry about comorbidities, and many of these complications are chronic. And so one of the issues in older adults is, what do we think someone's lifespan is? And that, of course, depends on a lot of their complications, their comorbidities. But many of these that I'm talking about here are chronic. And so the ones on the left are ones that, we traditionally learn about with diabetes. And the one on the right are many of the comorbidities. And we've also found now that individuals with diabetes are disproportionately affected by depression, but then also certain cancers and fractures, as well as fatty liver. And I would say that of these complications, these three down here are probably the ones that directly affect quality of life and function the most. And of course, vision loss affects diabetes self-management abilities. So when we look at the building blocks of diabetes therapy, I think there are many things that can change over time and might change the way we think about diabetes therapy in older adults. So one is giving more diabetes self-management support and education. So even if someone has received this in the past, things change and then situations change. So during transitions of care and after hospitalizations, et cetera, there might be a need to give more support and education, and then also modifications in glucose lowering medication. So I wanted to move on now to the use of A1C as a surrogate outcome in diabetes, because this affects our question of targets and kind of where that came from. And so as you know, the DCCT that was published back in 1993 demonstrated this progressive increase in retinopathy and in nephropathy as A1C rose in patients with type 1 diabetes. UKPDS showed that in type 2 diabetes. And lowering the A1C by 10% reduced this risk by 35% of retinopathy and 25 to 44% of nephropathy. But what was found is that as A1C levels fell, the risk of severe hypoglycemia rose, and those paths crossed at about 7 to 8%, which led the ADA to establish this goal of less than 7% for most individuals with diabetes. The problem is that this relationship between diabetes and complications in A1C is not completely linear in every case. And so it's true for retinopathy, a microvascular complication, but not true for macrovascular complications. And so there's a J-curve for cardiovascular and renal complications, and there's increasing risk with an A1C of about 6.5%, below 6.5%. This was in the ADVANCE trial, which is an intensive glucose control trial in older adults. So there are many problems with using A1C as the sole guide for glucose lowering therapy. So the A1C may not be an accurate reflection of average plasma glucose. So there are many situations of increased red cell turnover, such as dialysis, recent blood loss, transfusion, erythropoietin therapy that can falsely increase or decrease A1C. And then also, of course, A1C is an average. So it doesn't give us information about glucose variability, which is a very, very important factor in hypoglycemia. But the conclusion that was drawn from DCCT, as well as the EDIC long-term follow-up of DCCT, was this relationship. So what was seen is that in the DCCT, in the intensive group, the incidence of severe hypoglycemia was threefold higher. The A1C target was lower. During the long-term follow-up of the DCCT, which was published as the EDIC study, the A1C averages were similar between the intensive and conventional groups, and the incidence of severe hypoglycemia was similar between groups. So the conclusion was drawn that severe hypoglycemia could be avoided by increasing the target A1C. But it turns out subsequently that this isn't completely true. And so subsequent data showed that there was comparable prevalence of severe hypoglycemia across a broad A1C range in adolescents and adults, including the elderly. So I'll show you one such study. So this was a study, a small study in 65 individuals with type 2 diabetes, age 76 or so on average. And this group of individuals all had type 2 diabetes. They were all on at least 2 injections of insulin a day. They wore a CGM, or continuous glucose monitor, for 5 days, kept detailed diaries of symptoms, and then also did finger stick glucoses. And so what was found is that across this range of A1Cs at the bottom, so 7% or less, greater than 9% on the right side, and then in between here, you can see that the duration of hypoglycemia as measured by that continuous glucose monitor is similar actually across the entire A1C range. So this lightest green bar is glucoses of less than 70. This is less than 60, this is less than 50. So you can see that actually they're all fairly similar. And then this dark green is nocturnal hypoglycemia. So this is the number of minutes over those 5 days of wearing the CGM. So that was one thing that started to tell us that maybe the A1C isn't enough, or increasing that A1C isn't enough to prevent hypoglycemia. So here's another study by Munshi et al. That gave us additional information that maybe we were missing episodes of hypoglycemia even by raising the A1C target. So in this study, it was also a small study, so 40 individuals, 28 with type 2 and the rest with type 1. Mean age was 75, and the mean A1C in this group was 9.3%. And these individuals had average diabetes duration of quite a long time, so 22 years, and 93% were on insulin, with or without an oral agent, and the rest were on a sulfonylurea. So remember that this comparison is sulfonylurea. So everyone underwent continuous glucose monitoring for 3 days. They did finger sticks 4 times a day. They did a detailed symptom diary. And what was found was really surprising. And so I think the magnitude of this was really surprising to the investigators and to everyone who read about this. And so about 2/3 of people had at least one episode of hypoglycemia during those 3 days. The average was 4 episodes lasting 46 minutes each. 3/4 of people had a glucose of less than 60, and about half had a glucose of less than 50. And remember, these are individuals with an A1C of about 9.3%. More than 2/3 had an episode of nocturnal hypoglycemia. And then it turns out that 93% of these hypoglycemic episodes were unrecognized by either symptoms or by finger stick glucose. So increasing that A1C is not enough. And when you see an A1C of 9%, doesn't mean that someone is not having hypoglycemia. So I think, to me, that's what this tells me in older individuals. So I think that's my first message, is that reducing and avoiding hypoglycemia in older adults is not as simple as increasing the A1C target. So we've talked about these first 2 objectives, defining hypoglycemia, and then now our next is to talk about risk factors and clinical clues for undetected hypoglycemia and hypoglycemia unawareness. So the risk factors for hypoglycemia are listed here, and this has kind of been demonstrated over and over. There are other ones that sometimes fall out, but I think these are really the top ones. And this reference down here, diabetes in older adults, the consensus report, is about 10 years old. It's surprisingly still very current. And so the risk factors for hypoglycemia include insulin deficiency, and this insulin production by the pancreas decreases over time the longer you've had diabetes. So insulin deficiency, that's why it disproportionately affects older adults, especially those who have had diabetes for decades. Insulin therapy itself, insulin secretagogue therapy, and that's just because insulin secretagogues cause beta cells to produce insulin no matter what the glucose, unlike many of our newer agents, which have glucose responsive insulin secretion, cause glucose responsive insulin secretion. Renal insufficiency, which is much more common in older adults, cognitive decline. So cognitive decline increases the risk for severe hypoglycemia, but it turns out that severe hypoglycemia also increases the risk of dementia. So it's a back and forth relationship. A longer duration of diabetes, having had an episode of antecedent hypoglycemia increases your risk of subsequent hypoglycemia. Erratic meals, erratic PO intake, and then erratic exercise or activity. And so how do you assess for hypoglycemia? So some of the key questions to ask are, have you skipped any meals in the past week or month? Or in the past month, have you forgotten that you took a diabetes medication and took it again? So those two are probably very, very key that we'll often forget to ask about. And then the third question is directly asking about it. So have you had any glucose below 70 since your last visit? But then digging a little bit deeper. If yes, how often? So how urgent is this? And have you had any episodes that required help from others to treat? Did you need glucagon, or did you need to call 911 or go to the ER? What time of day did they occur? And then what do you think caused them? And so really digging at what might be causing these episodes and how, whether or not they're happening, how frequently they're happening. And one of the things that we are always on the lookout for in our clinics is hypoglycemia unawareness. And so this is from one of the original study trying to detect hypoglycemia unawareness that was published back in 1995 by Clark et al. And the questions on that survey included, included all of these. And so the first is, I sometimes or no longer have symptoms when my glucose is low. They've lost symptoms that used to occur when the blood sugar was low. Subjects who had at least one episode of moderate hypoglycemia in the past 6 months, yes or no. And these are episodes where they might feel confused, disoriented, lethargic, and were unable to treat themselves. Or an episode of severe hypoglycemia in the past year. So this is becoming unconscious from the hypoglycemia, having a seizure, needing glucagon or IV glucose. And then if someone said that they had a glucose of less than 70 in the past month with symptoms, that number, if that number is less than the number of episodes of hypoglycemia or glucose less than 70 in the past month without symptoms, then that also increased the risk that someone might have hypoglycemia unawareness. If someone says that their glucose needs to go as low as the 40s or below before they feel symptoms, then it's likely that they're having hypoglycemia unawareness. And lastly, if someone says that they can only sometimes, rarely or never tell by their symptoms that their glucose is low. So hypoglycemia unawareness in this particular study was if you said yes to 4 or more of these, and then hypoglycemia aware is if you had 2 or fewer yeses here. So from that study, that's original study, what was found is that if you divide the group into those who are aware versus those had reduced awareness, and again, this is a relatively small study, but very detailed, those with reduced awareness had a lot more episodes, but they weren't able to tell that they were having them. So that's kind of the bottom line here. So when we assess for hypoglycemia unawareness, some of the questions that we ask in clinic are, can you tell when your glucose is going low? Have you lost some of the symptoms you used to feel when your glucose goes low? At what glucose level do you start to feel symptoms of hypoglycemia? Have you had an episode of hypoglycemia in the past 6 months that required assistance from another person? And then have you called 911 or gone to the ER for hypoglycemia in the past year? So these questions can help assess for hypoglycemia unawareness. So I think this framework is really great. So this is from the 2022 Standards of Medical Care section. Now it's section 13. They keep adding sections and pages every year. This is section 13 now, not 12, on a framework for considering treatment goals for glycemia in older adults with diabetes. So these are divided into those who are healthy, those who are complex or maybe intermediate, and then those who are very complex or in poor health. And these might include individuals in long-term care facilities or have end-stage chronic illnesses or moderate to severe cognitive impairment. So in those who are healthy, a reasonable goal might be an A1C of less than about 7 to 7.5%. And one of the things to remember is that this depends on how they got there. And so many of the studies, including the Accord trial, targeted an A1C of less than 6% and then used insulin to get there. And they were usually very complex regimens. And so targeting an A1C of less than 7% in someone who's on a lot of insulin or a complex insulin regimen is very, very different from targeting an A1C less than 7% in someone on metformin. But in healthy older adults, this would be a reasonable A1C goal. And so what we tell our patients is, here's the goal that we're looking for fasting or preprandial glucose. Here's our goal for bedtime glucose, although I would argue that 80 is probably a bit on the low side. For the very complex patients with limited remaining life expectancy, of course, the benefits of chronic glucose control and on these complications is a lot lower. And so those are the patients where we don't rely on an A1C. And so we'll talk about the different strategies independent of A1C that can help prevent hypoglycemia. But here you might be targeting fasting or preprandial glucoses of 100 to 180, bedtime glucoses that are higher, and then complex or intermediate patients, which I think make up a bulk of our patients. You could bulk of older individuals with complex comorbidities and complications. A reasonable goal might be an A1C of less than 8%. And fasting here, and then bedtime of 100 to 180. So I think this is a really nice framework for trying to figure out glycemic treatment goals. But there's more to that than to reducing hypoglycemia. And so just a few things I wanted to point out quickly, and this is just that the ADA recognizes that there are a lot of aspects of diabetes treatment in older adults and reducing hypoglycemia that are important to keep in mind. So number one is most important is considering a comprehensive assessment. So of course, this is important in all of our patients and in many different conditions, but in particular diabetes. And this gives us a framework to try to figure out what targets, what therapeutic approaches to use. Screening for the geriatric syndromes is incredibly important. They affect diabetes self-management a lot and affect quality of life a lot. And then lastly, screening for early detection of mild cognitive impairment or dementia. That can really, and doing this repeatedly, because this can really change or should change our treatment approaches and goals. The next is the specific statement about risk of hypoglycemia. So the episodes of hypoglycemia should be ascertained and addressed at routine visits. And then this recommendation that older adults with type 1 should have continuous glucose monitoring or new diabetes technology considered to reduce hypoglycemia. And then lastly, some A1C targets, just as I showed you in that table, which is in healthy adults, older adults, A1C of less than 7 to 7.5%. In the intermediate group, A1C of less than 8%. And then the statement about how we're trying to balance these glycemic goals, but then also trying to avoid uncontrolled hyperglycemia. So just an interim summary, because we're most of the way through. I still have some more to talk about tailoring, but just to make the points that diabetes is common in older adults, probably more than 1 in 4 age 65 and older. It's associated with the highest rates of diabetes complications and ER visits. There's marked heterogeneity in diabetes duration, presence, and severity of comorbidities. Simply increasing that A1C target isn't enough to avoid hypoglycemia, but we may need to increase that target compared to younger adults. Going over the international definitions for hypoglycemia, reviewing the risk factors for hypoglycemia and assessing this at every visit, and then being on the lookout for hypoglycemia unawareness. So let's move on to the rest of the talk. So now we'll talk about tailoring treatment regimens to reduce hypoglycemia. So one thing that I wanted to show you is kind of the other part of the study on those older adults who are on 2 or more injections of insulin. So again, this was a group of 65 individuals age 76, wearing a continuous glucose monitor for 5 days and on 2 or more injections of insulin. So after simplifying the regimen from 2 or more injections to once a day basal insulin plus non-insulin agents, and then repeating the study about 6 months later with a continuous glucose monitor, there's a marked decrease in the duration of hypoglycemia. So the biggest decrease is probably in the group with an A1C of 7% or less, but there's a marked decrease in the rest of the group as well in all levels of hypoglycemia. And so again, here was the slide I showed you before with up to 300 minutes of hypoglycemia over the course of 5 days in all of these older individuals on 2 or more injections of insulin. So as soon as you simplify the regimen to once a day basal plus non-insulin agents, the investigators were able to reduce the duration of hypoglycemia, I would say by at least half, and sometimes much more than that. So just that single intervention. And there's a newer guideline that came out since the 2012 ADA consensus statement, which was from the Endocrine Society. So this is treatment of diabetes in older adults. It came out in 2019. Dr. Boris Drasnin from our group was a co-author on this clinical practice guideline. And I think it's a really, really great guideline to go and look up and look through. It's a terrific reference. So there are many useful recommendations in this clinical practice guideline, but I think that just a few of the ones that I pulled out to emphasize today are, number one, that in older adults with diabetes, we should be designing these treatment regimens specifically to minimize hypoglycemia. And I'll talk a little bit more about how to do that. Also, for individuals who are on insulin, frequent finger sticks and or continuous glucose monitoring, in addition to the A1C. And then this other specific recommendation that in individuals with congestive heart failure to avoid agents that might worsen the heart failure. So glinides or those shorter acting insulin secretagogues, the thiazolidine diones, and then certain DPP-4 inhibitors. So I've listed that out in a future slide. In terms of glycemic management specifically, recommending metformin as the initial oral medication, and then recommending other oral or injectable agents. And then lastly, to use insulin sparingly. And then trying to keep the glycemic regimens as simple as possible. So what does that mean? So, and what's the difference between simplification versus deintensification and de-prescribing? So treatment regimen simplification is just decreasing the complexity. So decreasing the frequency of medications, fewer glucose checks, and then also decreasing the need for calculations. So needing to calculate different insulin doses, using insulin to carbohydrate ratios, et cetera, correction factors. And so that's simplification. De-intensification has more to do with decreasing the dose, decreasing the frequency of administration of a treatment, or discontinuing a treatment altogether. So that's kind of a distinction that's made between these two concepts. So when to consider this? So I'll show you the table in the next slide, but the bottom line is to consider simplifying or de-intensifying a regimen in healthy older adults if they're having severe or recurrent hypoglycemia on insulin, regardless of the A1C, if they're having wide glucose excursions, or if there's cognitive or functional decline after an acute illness. And then to consider simplifying or de-intensifying the regimen in those with complex or intermediate health status, if any of these occur, or if you find that the patient's unable to manage the complexity of the insulin regimen, if there's polypharmacy, or if there's significant change in social circumstances. So things like loss of a caregiver, a change in living situation, financial difficulties. And so this is the table that is in the 2022 standards about when simplification might be required and when treatment deintensification or deprescribing might be required. So many of these overlap, and I've tried to capture that in the slide before. And so the next point that I really wanted to make is that reducing and avoiding hypoglycemia in older adults may require increasing the target, but is really linked more to treatment strategy. So the type of agent, the burden of the regimen, and the complexity. And so how do we choose diabetes medications to avoid hypoglycemia in older adults? So we would choose low hypoglycemia risk agents over high risk. So the high risk are sulfonylureas, glinides, insulin. Surprisingly and really, really amazingly, our newer classes of diabetes agents are associated with low hypoglycemia risk and little weight gain. So really great. We would choose oral over injected. We would choose less frequent administration over more frequent, low dose over high dose if you have adequate glucose lowering efficacy to decrease the risk of adverse effects. We, of course, are looking at side effect profile. And then if we're using insulin, then we would choose an insulin analog over a non-analog, such as NPH or regular. So the data for insulin degludec, which the trade name is Tresiba, is quite good for decreasing the risk over even agents like glargine, but certainly over NPH and regular. And if you're using insulin, we would choose basal insulin over a complex basal bolus or premixed insulin regimen. Basal bolus regimens, of course, are incredibly complex, and premixed are fixed dose and assume a level of PO intake that may not fit what a patient is actually doing. And so the preferred agents with low risk of hypoglycemia are listed here. And when I was giving a talk for the local ACP chapter, it was suggested as I was preparing that talk that I try to do this because there's so many different new diabetes medications and classes to try to figure out a way to help people remember them. So the GLP-1 receptor agonists, which are the tides, they're all sub-Q. There's one semaglutide that's PO, Rybelsus. The SGLT2 inhibitors, which are the gliflozins, DPP4 inhibitors, the gliptins. And so I put this in parentheses just because there aren't a lot of benefits for cardiovascular or renal complications or heart failure there aren't with DPP4 inhibitors. So even though they're simple to give and have few side effects, we try to consider these others first, depending on the patient. If you're using insulin, try to use once daily basal if possible, and try to use basal insulin analogs. And these are available, some of these are available in combination with GLP-1 receptor agonists, which also decrease complexity. And of course, avoiding sulfonylureas. But if we're using them, to choose shorter acting ones such as glipizide. The glinides are shorter acting, so these are preferred over sulfonylureas. But the problem is that you have to give them before each meal. And so that can increase complexity. Insulin, if using, then the basal insulin analogs preferred over NPH. So these are the ones listed. I've kind of listed them in my order of preference. So Tresiba or degludec at the top, glargine next, and then these others with detamir at the very bottom because of problems with dosing and potency and other weight gain and other things. And then basal only regimens are preferred over basal bolus or premixed. What about considerations in renal dysfunction, which is quite common in older adults? Remembering to reduce metformin for a GFR of less than 45, stopping if the GFR is less than 30. And then if using GLP-1 receptor agonists, just really being careful to avoid hypovolemia, which can increase the risk of adverse effects of the drugs. And the preferred ones are really semaglutide, liraglutide, dulaglutide for the other benefits. And then these can actually be used in fairly severe renal dysfunction, short of dialysis. and Bydureon can't. And so you would stop that with a GFR of less than 45. With the SGLT2 inhibitors, start with a lower dose and then stop if your GFR is less than 30, or with dapagliflozin 25. And then these are really the preferred ones because of additional benefits on renal and cardiovascular risk. And then remembering to adjust the DPP4 inhibitor dose, except for linagliptin, which can be used at any level of GFR. And alogliptin and saxagliptin were the ones that were shown to increase risk of hospitalization for heart failure in the clinical trials. And so you would avoid those in individuals with heart failure. And so I've listed here on this table the dose reductions and the GFR levels, which are slightly different for each one. So I've talked a lot about the medications, and I've kind of talked about how the newer diabetes medication classes are associated with lower risk of hypoglycemia. And of course, we're always limited by things like cost and coverage. And so that can really limit, especially when people are in the Medicare donut hole, being able to afford these medications that have the lower risk of hypoglycemia. Comorbidities often will limit our use of these non-insulin agents. So that's why we'll often be turning to insulin. These side effects, potential side effects of different agents, complexity can really affect adherence, and injections can affect adherence for people with needle phobia. And then of course, polypharmacy, when we're starting to add on multiple agents to try to treat one condition and someone has many more conditions than that. So all of these are limiting factors. So I'd like to spend the last part of my time with you talking about diabetes technologies. And so the diabetes technologies that we're really talking about are insulin pumps that have been around for a long time now, over 4 decades. So these deliver continuous subcutaneous insulin through a tubing, except there's one tubeless device. There's a reservoir for insulin, there's tubing, there's a subcutaneous catheter. There is one tubeless system available, the Omnipod. And we generally use this for patients with type 1 or patients who have had a total pancreatectomy, or patients who, very rare patients with type 2. Oftentimes patients with type 2, this is pretty complex system to have to learn when the risk for hypoglycemia is lower and when doses of insulin are very high. So in people, especially in people with severe insulin resistance who are on very high doses of insulin, it doesn't make sense to use an insulin pump because the reservoir only holds so much insulin, 300 units at the most. Probably the most considered device that may be helpful in reducing hypoglycemia in older adults is continuous glucose monitoring. And now, instead of needing a separate device to see the glucose, there are phone apps available so that people can, if they're using a smartphone, and are comfortable with using an app and using their phone to scan or to see glucoses, this can work very well. And I'll talk a little more about what that looks like in a second. The newest is combining those two. So the hybrid closed loop system that can automate insulin delivery. And so this has been revolutionary for individuals with type 1 and has actually allowed people to be able to sleep through the night because they don't need to worry so much about nocturnal hypoglycemia. And then for people who are on complex insulin regimens, it's incredibly helpful to have a connected insulin pen. So these used to be called smart pens, but now we're trying to move towards changing it to connected insulin pens. So they're pens that record the time and the amount of bolus insulin. They can help calculate your bolus. So it can pretty much do almost everything that a pump can do except to deliver the insulin through tubing. So here's how it looks. So here's the glucose sensor for a continuous glucose monitor, a transmitter, and then it goes to a receiver, which can be a phone or a separate kind of phone-sized device. And so it's measuring interstitial glucose. And so you might see someone with both an insulin pump as well as a continuous glucose monitor. And so the CGM, of course, is a wearable sensor. And the Dexcom G6 is one example of this. And in the endocrine clinic, this is actually our preferred CGM because it's incredibly accurate. And so compared and easy to use compared to the other ones out there. And it can pair with one of the insulin pumps to as a closed loop system. So just like the others, there's frequent sampling of interstitial fluid for glucose. So for the Dexcom G6, every 5 minutes, and you wear the sensor for up to 10 days. And it gives you both a glucose value, a trend arrow. So is your glucose going up? Is it going down? Is it staying the same? And then this here, you can see a double arrow. So it's 84 and it's dropping fast is what this one shows. And then it can also show you a glucose curve. This shows for the past 8 hours what your glucose is doing. That you can also look at views for the past 24, past week, and past 30 days and 90 days. There are problems with this. So if you're taking very, very high doses, higher than prescribed doses of acetaminophen, it can interfere with the accuracy of the Dexcom G6. For imaging, you have to wear a lead apron over the sensor, and then you have to remove this for MRIs. And so I wanted to show you an example of a CGM download in one of my patients. And so this is when we download the continuous glucose monitor, we get an average glucose, we get the standard deviation. Normally you should get what's called a glucose management indicator, which is kind of like an A1C, but using the continuous glucose monitor values. We look at this graph, which is an overall time and range. So this is for the past 14 days. What percent of time was the person's glucose in the range of between 70 to 180 during the day, 80 to 150 at night. So for her, it was 47%, which is below the goal in many patients or most patients of 70%. But she has very little hypoglycemia, so less than 1% lows, 0 very low, and most of her glucoses are high. And you can see that she was wearing her CGM about 80% of the time over the past 2 weeks. Here's other information that you get from the download. So you can see kind of an average day from midnight to midnight, the median glucoses, and then what the glucose variability is. So how wide these dotted green lines are. And then here's another way to see that. And I really like this view because it helps me figure out what I need to be doing. I look for the gray first. So how often is she having any glucoses lower than this red line? And then where's the average glucose? And then where's the most variability? So we have studies now that show that CGM can identify those at high risk for hypoglycemia. And one of the ways we do this is looking at coefficient of variation. So this is a measure of glucose variability. So in this particular study, if you divide individuals into coefficient of variation of greater than 36% or less than 36%, you can see that the A1Cs are similar between the two groups, but the time spent in hypoglycemia is much, much higher, both at night as well as during the day in this group of individuals with high variability. So this is one way to use the CGM aside from looking at things like average glucose. And so when would you consider referral to a specialist? So I think there are some different situations. So when you think that someone needs diabetes technologies, when you are worried about this high risk of hypoglycemia, or you have evidence that people have hypoglycemia unawareness, these are some other situations where you might consider that. So individuals with type 1 or after total pancreatectomy, I think that the specialists often have clinics that are set up to be able to help people with technology, get them set up, work with the insurance companies on coverage, et cetera. It's a lot to do, and then troubleshooting. Individuals with wide glycemic excursions or variability, as I just showed you, people with stage 4, so very severe CKD or end-stage renal disease, hypoglycemia unawareness, and those with severe complications. So what we talked about over the past 50 minutes or so was some of the epidemiology of diabetes in older adults, the International Hypoglycemia Study Group definitions of hypoglycemia. We talked about the fact that time in hypoglycemia doesn't correlate with A1C. And so increasing the A1C target itself that's not enough to reduce hypoglycemia. But when we're individualizing these glucose goals, it's a balance between not making the A1C goal too low versus too high. Looking for hypoglycemia unawareness is really important because we may be missing episodes, and we want people to recover their awareness by minimizing hypoglycemia. It takes a few weeks to do that. We want people to be aware when they're hypoglycemic, so we can regain awareness that way. And then thinking about when to consider simplification, deintensification, and deprescribing. And then lastly, considering the use of diabetes technology in individuals with type 1, as well as individuals with type 2 who are very complex and having a lot of hypoglycemia or at high risk. So in conclusion, the title of my, or the subtitle of my grand rounds was a little bit deceptive, a little bit of a trick, because I made it sound like maybe I was going to talk only about the A1C goal. But I think we also talked about what to do besides looking at the A1C. So thinking about other targets, and then also other strategies. And so it's important to set an A1C target while keeping in mind the overall patient, not being falsely assured that you've avoided hypoglycemia with that higher target. So it's important to design a diabetes treatment regimen that reduces the risk of hypoglycemia using specific agents that are associated with low risk of hypoglycemia, and then also more simplified regimens, and then reassessing that often and verifying. So it's important to verify with glucose values, finger sticks, and or a continuous glucose monitor, and then referring complex patients and or diabetes for complex patients and or for diabetes technology. And then lastly, I just wanted to list some of the really key references that I referred to during the talk. And one I didn't mention, and this is just diabetes in long-term care and skilled nursing facilities. And so that's the end of my slides, and I am happy to answer any questions. Thank you so much for listening.
Great. Thank you so much, Cecilia. That was a great presentation. We really appreciate it. A couple of questions coming in. So one participant is asking, given the risks of harm associated with hypoglycemia in older adults, why is it that nearly all hospitalized patients are given or discharged with sliding scale insulin?
Oof, that's a great question. So I'll answer, I think it's two separate things. So we still don't have enough, we have some data, some randomized controlled trials for non-insulin agents in the hospital. But I think the greatest concerns are just the adverse effects of non-insulin agents. And so there have been a number of trials published by Perez et al., including one of our colleagues, Neda Razuli, on DPP-4 inhibitors use in the hospital. So a lot of the time it's because of the potential adverse effects of these non-insulin agents limiting their use in the hospital setting. And then the second is sometimes just the degree of hyperglycemia and stress hyperglycemia can be so much that these non-insulin agents just aren't effective enough to provide adequate glycemic control. The discharge part, I think that's a huge question. I feel like that's completely separate. We should not be discharging most patients on complex regimens if they're not appropriate. So I and my team are always rethinking regimens and trying to use that opportunity to say, okay, this is how we see what the body physiologically needs. What does the patient overall need? What can they do? What are they willing to do? What's the situation they're being discharged in? And in most cases, that sliding scale is not appropriate. So I think that shouldn't be happening.
Thank you. Another question is about continuous glucose monitoring. So how hard is it to obtain this for our older adult patients? And can insurance coverage be a challenge in trying to get this?
So the coverage for type 1 has gotten to be very good. And actually last fall, Colorado Medicaid started covering it for type 1 as well. So that was a huge change. They actually weren't covering it for type 1 before. The Medicare coverage guidelines actually, they will not cover, first of all, they will cover patients with type 2, which is great. but unfortunately, they'll only cover it for patients with type 2 who are on 3 or more injections of insulin a day. And then there's also a period of proving that you're checking your finger sticks often enough, so you're so-called motivated enough to be able to make use of it. So there are these restrictive guidelines. But once you kind of jump through those hoops and you have that documentation in your note, patients need to be seen at least every 6 months to be evaluated for this for Medicare to cover it. So there's just a list of different restrictions and guidelines we have to follow to get it covered.
Okay, thank you. Let's see, exceptional lecture, thank you. And given your recommended targets of A1C less than 8, what high individual sugar target would you use for nursing calling in a high blood sugar?
Let's see, individual use for nursing. So I'm gonna assume, I'm not sure if this is in the hospital or if this is maybe at a skilled nursing facility, because those I think would be, a skilled nursing facility. So, so this is a really, really great question. So I didn't have a chance to talk about skilled nursing facilities, long-term care facilities. I think that there are a lot of systemic and structural problems with dealing with diabetes in those settings, and having protocols in place and having staff be on board with how to take care of diabetes and how to manage having hypoglycemia protocols, et cetera, are important. But I think that I think it depends. And so it depends on the patient. And I think that probably having some parameters for checking ketones in patients with type 1 or at high risk for ketoacidosis would be important. That would be one thing that could potentially raise our goal for our target for that nursing call. Because if someone had a higher glucose of, let's say, 250, but didn't have ketones, maybe that we could treat that with pushing fluids and close monitoring. If I had to choose a target, I might say 300. But I think that some people would say if you have repeated glucoses above 250, so let's say maybe a couple of days in a row, then for sure you should be modifying something. So.
Thank you. So a number of other just comments saying this was a really helpful lecture. So we're at time, so we're going to go ahead and wrap up here. But again, Dr. Low Wang, thank you so much for this presentation. We really appreciate your being here. And everyone participating, please check your email and try to respond to the evaluation that will come out later today. So thanks everyone, and see you in a couple weeks.
Thank you so much. Thanks for